Okay, good afternoon everyone. Welcome to the afternoon session of Oculoplastics. Today we are going to start with Dr. Bradford Lee, who's going to be talking to us about updates in medical and surgical management of thyroid eye disease.
Okay, good afternoon everyone. Hopefully everyone still has some sugar running through your blood to stay awake for this presentation. But I'm going to speak a little bit about one of my favorite topics, which is a specialty in my practice of thyroid eye disease. My colleagues on the program are going to be covering eyelid retraction, repair, and orbital decompression. So I'm going to try to focus on some of the the complex medical management and advanced systemic and other therapies that are available in treating thyroid eye disease patients. In my experience, if you look at practice patterns around the US and the UK and Europe and the Middle East, there's such a wide variety of ways that people manage or fail to manage thyroid eye disease, and hopefully, I'll be able to share some of my thoughts on how to manage some of the more complex and complicated patients. This is a brief schematic showing the lymphocytes in the bloodstream. As you all know, thyroid eye disease is an autoimmune condition whereby the lymphocytes produce circulating immunoglobulins that circulate to the thyroid gland, causing the endocrine abnormality, but they also circulate to the orbit, affecting the orbital fibroblasts, mediating several processes, including orbital adipogenesis and expansion of the fat, as well as enlargement of the extraocular muscles via deposition of glycosaminoglycans, as well as fibrosis of the extraocular muscles and the levator muscle, which cause the restrictive strabismus and eyelid retraction. You all are very familiar with the clinical findings, so I won't waste time on that. But as you know, most patients with thyroid eye disease are Graves' disease patients, although there are various other thyroid abnormalities and euthyroid thyroid eye disease mixed in. Smoking is obviously terrible, increases the incidence, severity, and persistence of disease. Radioactive iodine is well known to worsen thyroid eye disease if not treated concurrently with steroids. And finally, what I tell patients about thyroidectomy is that it can sometimes improve thyroid eye disease, particularly if done in the active phase of disease. This is a schematic of Rundle's curve, with the y-axis being the severity of the thyroid eye disease. You can see the left side of the curve being the dynamic or inflammatory phase of disease, which is where we really focus on the medical management. If you do medical management in the right part of the curve, in the static phase, you're really wasting your time and exposing patients to unnecessary risk for adverse events. The right side of the curve, the static phase, is when we focus on surgical rehabilitation. One of the lab tests that I like to use in my practice is called the thyroid stimulating immunoglobulin, the TSI. And this is a lab test that's very often not fully utilized by endocrinologists because it really doesn't help them very much with their management. But for us, this is one of the TSH receptor antibodies, or the TRAbs, which has been shown to be the most correlated with thyroid eye disease. So higher levels, even before or early on in the disease, suggest a greater incidence of developing thyroid eye disease, as well as a potential future greater severity of disease. It also can aid in cases of euthyroid eye disease, where there's a question mark of what the real diagnosis is. And then I also like to use it as a type of biomarker for trending disease activity. If if the TSI level is increasing, I generally will try to shy away from doing definitive rehabilitative surgery because I feel it's still in evolution. If it's downtrending or stabilizing, that's reassuring to me. And a note, you don't need to necessarily wait until the TSI goes back to normal because you could be waiting forever. So as long as it's stable, even if it's stably high, I feel comfortable. So our first case here is a 64-year-old lady who had come to me with diplopia, pain, and decreasing vision. She had seen a whole number of different specialists in ophthalmology, endocrine, rheumatology, and she had been given a variety of diagnoses: idiopathic orbital inflammation, possible lymphoma, possible thyroid eye disease, and there was really no consensus, and she was completely overwhelmed and confused. She had already had a superior rectus biopsy on the left side that showed inflammation, and they suspected IOI. And she was pretty refractory to 60 milligrams of prednisone, which was kind of baffling to the other physicians. And in reviewing the reams and reams of paperwork, when she came to me, I saw that there were TSI levels that were markedly elevated. 2790 is about the highest I've ever seen, even though all of her thyroid function tests had always been normal. And in the MRI up there, you can see that there's marked elevation of the superior rectus muscle and the levator muscle, which is kind of atypical because typically patients present with enlargement of the inferior rectus muscle with restricted up gaze, whereas she had restricted down gaze in the left eye, and periorbital edema left greater than right. So as soon as I saw the TSI, I was like, there's really no question what this is. It's not IOI. This is euthyroid thyroid eye disease. And we proceeded to treat her very aggressively. She had compressive optic neuropathy and was obviously high risk from smoking. So all of the patients who come in for thyroid eye disease, they all need endocrine optimization. So whether that's achieved by antithyroid medications like methimazole, if they're doing well with that, I'm generally happy with that. Typically, I try to avoid radioactive iodine, although studies have shown that if you treat concurrently with steroids, there really is no increased risk of progression of the disease. And then thyroidectomy. A lot of patients, as well, should I have my thyroid out? Is it going to help my eyes? There was a study that came out a couple of years ago that showed in patients with Graves' disease without thyroid eye disease, having a thyroidectomy reduced the hazard ratio dramatically compared to radioactive iodine. And so I typically tell patients it can sometimes help with thyroid eye disease, but there's no guarantee. Sometimes it really doesn't do much. So you don't want to give them a false hope that their eyes will dramatically enter the stable phase as soon as their thyroid gland comes out. Other treatment options, and these are things that I talk about with all of my thyroid patients, whether mild to severe, smoking cessation. Obviously, selenium supplementation. There's been studies showing that selenium supplementation can help reduce the onset of thyroid eye disease, and it's a very benign antioxidant involved in thyroid function. And then statins. This is something that I think is very underappreciated. In that same, cross-sectional study, they found that they looked at thousands and thousands of patients with Graves' disease, and if they had been on statins for 60 days in the last year, they had a 40% reduced hazard ratio of developing thyroid eye disease. And this was not true of other cholesterol-lowering drugs. And in my own work at Bascom Palmer and at UC San Diego, which I actually did with Dr. Al-Madin, we looked at differential gene expression in orbital adipocytes in active thyroid eye disease patients. We looked at which genes were upregulated and downregulated in these severe active inflamed patients. And sure enough, the LDL receptor, the VLDL receptor, the apolipoprotein B receptor, they were all, highly correlated. In fact, 35 out of the 328 genes were linked to, to the statin pathways. So I typically now tell patients, if you at all have high cholesterol, it's worth starting a statin. Finally, when you have patients who are severe or they have a lot of muscle involvement, muscle fibrosis, diplopia, and you just see that they're going down the wrong path, I reserve options like systemic steroids, radiation therapy, and peribulbar or eyelid injections of Kenalog. For systemic steroids, the general feeling is that while it can reduce inflammation, there's oftentimes recurrence once you stop the steroids. I ideally try to do the IV steroids, the Cahaley protocol, although sometimes that's logistically difficult and we do oral steroids. There have been studies showing that IV steroids have greater efficacy with lower side effect profile. Radiation therapy is also a long-standing treatment for this disease. There have been a couple of excellent studies recently showing that combining radiation therapy with either IV or oral steroids has a dramatic role in either reducing the risk of developing compressive optic neuropathy or treating compressive optic neuropathy so definitively that 96% of these patients did not need an urgent orbital decompression in that really active hot period. So in my really bad patients, I almost always try to combine these two if at all possible. And then finally, peribulbar and forniceal Kenalog injections are something that we often overlook. And in my practice, I like to do this for upper lid retraction. There's a recent paper out of Korea showing that it can cause permanent improvement in upper lid retraction, obviating the need for surgery. And there's also been other studies showing that it improved diplopia, extraocular muscle volume, and clinical activity score. So this is another challenging patient of mine. He had a toxic adenoma. He was a previous smoker, and he said, "Doc, I cannot go off my warfarin. I have a metal heart valve. There's no way I can go off of it." So I said, "Well, okay, you're severely affected. You have tons of chemosis. Your vision has gone down," and his vision was reduced in both eyes to 20/70 OU. The optic nerve, both of them were edematous. You can just see dramatic chemosis and restricted motility. And this is a patient after undergoing the Kohaley protocol with IV steroids along with orbital radiation. He basically said, "Doc, I feel like my eyes are back to normal almost completely. All of the optic nerve had edema resolved, the chemosis, his diplopia, proptosis, IOP issues, everything returned pretty much back to normal. He did develop a cataract later, which was taken care of." So finally we get to what I believe is really going to be the future, if not already the present, of medical management. And this is more targeted steroid-sparing biological agents. Rituximab is widely used in Europe by endocrinologists, and even though there have been conflicting studies, out of the Mayo Clinic they found that there wasn't much of an improvement. My understanding of that is that they were treating patients too far out from disease onset when they're approaching the quiescent phase. So all of these things, if you're in the quiescent phase without active inflammation, you're wasting your time. But if you can get the patients early, treat them while they're hot and actively inflamed, rituximab, works great. Tocilizumab is something that I've used on various patients in the IV and subcutaneous form. There's been some great studies showing dramatic improvement in CAS score, the clinical activity score, proptosis, diplopia. And then finally, of course, there was this great, groundbreaking study of teprotumumab, the anti-insulin-like growth factor 1 receptor, done by the University of Michigan group. And they showed that clinical activity score and proptosis were reduced at about 6 months. So this is in clinical trials right now. But I'd say tocilizumab is already FDA approved. It's kind of exciting for ophthalmology because it has an indication, at least in the US, for giant cell arteritis. It's well studied for rheumatoid arthritis. And this is something that you can already begin using if you can get approval and negotiate the financial aspects. So in terms of surgical rehabilitation, I'm not going to talk too much about this because my colleagues will cover this later. But obviously we talk about it being a 3-step process: decompression, eye alignment surgery, and eyelid surgery. We always like to do a customized graded orbital decompression. So I tell patients, we're not going to do the same decompression on every patient. If your eye is bulging 2 millimeters, that's a very different scenario than if your eye is bulging 8 millimeters. So depending on how much proptosis they have, I'll do a graded decompression. These are all the areas that we can work on: the fat, the lateral wall, the medial wall, the orbital floor, and the lateral orbital rim. And this is an example of one of my patients who just had an orbital decompression. I did it asymmetrically, so just a lateral wall on the right to get 3 millimeters of reduction, and a balanced decompression, lateral and medial wall on the left for 5 millimeters of decompression. This is another patient who also had asymmetric proptosis, and I did larger decompression on the right, smaller one on the left. And then one thing that I think we're going to see a lot and hear a lot more about in the future is what's called 3D navigation for the surgery. So obviously it's a challenging surgery. It's one that requires proper training because you can have CSF leaks and meningitis, and it can be a high-risk surgery. And so there's different systems now on the market, either using optical or electromagnetic stereotactic navigation. And these techniques are already being used by ENT, neurosurgery, orthopedics on a routine basis. And the potential, and I say potential because I think, there's still a bit of a learning curve for our field and optimization, gearing it for oculoplastic and orbital surgeons, is that it could be potentially more effective in allowing you to remove more bone faster and allowing you to go quicker as you approach your endpoints, and potentially safer if you can see when you're approaching the dura or the skull base to present a CSF leak. So I've been using this a little bit in my practice. I've probably done about maybe 10 cases so far now. You start with a little tracker device on the forehead. You have to register the patient. There's a board underneath the head, and you need to have done a very high resolution CT scan beforehand. And here you can see the crosshairs are where my probe is touching. So on the left here, you can see that I've actually gone above the roof of the orbit, really. So this is really like what we call a fourth wall. It's above the level of the orbit into this anterior superior marrow space that I've been able to go up. That's the area where I'm at. Over here, you can see in the axial cut that I'm right knocking on the door of the dura, on the inner table of the greater wing of the sphenoid. Over here, you can see, my probe is right at the back of the ethmoid sinuses, and over here, right up at the skull base. Any further, we could run into areas we don't want to go. And then over here, at the back of the orbital apex, again, you can see I'm right at the junction of the posterior ethmoids and the sphenoid sinus at the orbital apex. Over here along the floor, I like to use it to localize the position of the infraorbital nerve so that I personally like to decompress only the posterior medial floor to reduce the risk of hyposthesia in the V2 region. So that helps me go right up to my endpoint. So in conclusion, thyroid eye disease is a very poorly understood both by ophthalmologists, endocrinologists. It's a very complex and poorly understood disease that really requires multidisciplinary care and people who are really invested and interested in treating this disease. Most patients are undertreated during the active inflammatory phase of disease, and you definitely don't want to be treating patients too aggressively once they're in for medical reasons, if they're in the stable phase of disease. The TSI can be a useful biomarker and prognosticator when you're trying to determine how aggressively to manage these patients and to help you diagnose euthyroid patients and atypical presentations. And then there's numerous medical options that we have at our disposal to treat the active phase. And finally, I believe 3D navigation guided orbital decompression will become more useful and very helpful for orbital surgeons, and particularly for trainees who are learning to do this procedure in the future. And this is my buddy, Dr. Alameddin, one more time. We wrote the introductory chapter of the Oculofacial Plastic Reconstructive Surgery Atlas, which our mentors, produced with us. And this is our great mentor, Dr. Don Kikawa, after a mud run that we did in San Diego. So we like to work hard and play hard. Thank you.
Thank you very much. Well, to go on with grave disease, let's talk about eyelid retractions. The pointer. Excuse me, just 1 minute for the pointer.
Point the pointer on screen. Okay.
Thank you very much. So that, as you know, grave disease can associate exophthalmic ptosis, ocular muscle disorders, and eyelid retractions. We have in our examination to distinguish each part of the affection. First, The exophthalmos, as you can see here, can be associated with limitation of elevation of right eye, for this example, and left eyelid retraction. We have to distinguish the retraction, the real retraction that can be permanent or spasmodic, as we can see, from the false retraction due to proptosis or limitation of verticality movements. For example, this patient seems to have an eyelid retraction, as you can see here, but when he looks down, you can see there is no lid lag, and there is absolutely no retraction, at least when he is looking down. Another example for this patient, she has an asymmetric proptosis with an important exophthalmos on left eye, but she appears to have a big eyelid retraction. After, when she looked down, just a little part of retraction, and after only decompression surgery on left eye, as you can see, retraction disappeared totally. As an example, this patient, limitation of elevation on left eye, seems to have a retraction. And if you do the muscle surgery, strabismus surgery, verticality, you can see very less retraction, and only 1 millimeter still retraction can be operated by the entire approach. So you have to clearly distinguish what is the retraction and what is the proptosis or the eye limitation. When you are sure there is a real retraction, you can separate spasmodic from permanent retraction because the treatments are really different. What's happening when you have an eyelid retraction? The posterior lamella is the seat of adipocytes and other cells proliferation, creating fibrosis of the posterior tissue. It occurs cornea exposition with lag of ophthalmos and anesthetic consequence. How to make the difference between permanent and spasmodic retraction? This is on the lid lag. When you ask the patient to look down, the upper eyelid doesn't follow. This is the point of spasmodic retraction. For example, this patient, when she looks straight, she's okay, and you will see little spasms of the eyelid. When she opens, look now, you can see the typical spasms of the levator during the exam. This is a pure spasmodic retraction of the eyelid. This other case, it's a permanent retraction, and as you see, when she looks down, the eyelid doesn't follow the eye. So, what can we do to this patient to help them? Many techniques to treat the retraction. The first one is Botox. Botox, as we can see, muellerectomy is to say molar muscle excision, levator desinsertion. This is a third technique, blepharotomy of the entire eyelid, and material interposition. Everybody knows Botox now is used from several years in ophthalmology, from blepharospasm to strabismus, entropion, and eyelid retraction. What's the technique, the best technique for eyelid retraction in grave disease with Botox? Is done by posterior approach, tetracaine or novocaine instillation for topic anesthesia, eversion of the eyelid, and injection on 2 points. The posology, the quantity of Botox will depend on the level of retraction. For little retraction on 1 millimeter, something like this, about 5 units of Botox. To middle retraction, 1 to 3 millimeters, 7 units, and for severe retraction, more than 10 units at least, and more if you want. This is the way I inject by posterior approach in the superior part of the tarsus by subconjunctival way to the molar muscle and levator muscle. 2 points, as you can see here, on topic anesthesia in consultation. This is very efficient on the spasmodic form of the retraction. Quasi all the patients we treat had a benefit of this injection, not totally, but partial benefit for the permanent retraction. There's a good tolerance with very few side effects, with maximum effect in 1 month. As you can see, this patient, if we can play the video, at the beginning of gray disease, good retraction, as you can see, a spasmodic component, and just after retraction, injection, you can see a very good aspect with amelioration of the cosmetic aspect and the functional too, avoiding cornea complication due to the retraction. Some examples before and after retraction, injection, and this example is the limit of Botox in eyelids for retraction. As you can see, it's about 2 or 3 millimeters retraction, and it's much better, but not really perfect. Be careful not to make a ptosis, an acute ptosis. You can see on the left retraction of the eyelid, about 1 millimeter, and just after injection, she has a little ptosis, but it will be reversible. Here, a little retraction. This is a perfect case. 1 millimeter retraction on the right eye, before and after, and amelioration when she looks down with diminution of the lid lag, as you can see. Sometimes we have to re-inject about 2 or 3 months after the first injection, because we note that after 2 months after the injection, the retraction comes back slowly, but it comes back. So sometimes we have to re-inject twice or 3rd time. The posterior approach is beneficial because mostly more previsible, reproducible, less risk, and few side effects than the anterior percutaneous approach. The second possibility is the molarectomy, is to say take off all the molar muscle by posterior approach. The indication is quasi the same that toxin, is to say minimal retraction, less than 2 millimeters by conjunctival way. This technique is largely reproducible. This is a technique, local anesthesia, eversion of the upper eyelid, infiltration into the conjunctival way, permitting the dissection of the molar muscle, separating from the superior part of the tarsus. You can see here the conjunctival plane separated from the levator aponeurosis here. That's it. Molarectomy with upper eyelid blepharoplasty. The third technique is levator muscle recession. This is for permanent retraction, more than 2 millimeters. The way is anterior, and the usual way is to make the recession the double than the navel of the retraction. For example, if you want a 2 mm retraction, you will make a 4 mm recession. This is an ABAC. This technique permits to make the dosage during the surgery on local anesthesia. You see this retraction, we can associate upper eyelid blepharoplasty if necessary. We make the incision into the crease, passing the orbicular plane, muscle plane, opening the septoma, and as levator surgery, you can see the typical aspect of the levator muscle with fibrosis due to Graves' disease. You make the disinsertion, total disinsertion of the muscle, and so that you can here see the posterior plane, molar muscle, posterior plane, and you can make your recession of the muscle. Here is the molar muscle, then you can take off 2. This is our everyday technique for important retraction, as you can see. Good results with big retraction, or this patient, for example, unilateral Graves' disease retraction, only surgery on the eyelid, no exophthalmos, no ptosis, logging down, amelioration on lid lag, or this young patient with unilateral left eyelid retraction, as you can see. Another technique described is the transpalpebral blepharotomy. The indications are variable on the authors, but the technique is to cut all planes. It's to say the skin, the orbicularis muscle, the levator, the conjunctiva, without any dosage during the surgery. I'm not very used with this technique, but it seems to have good results. Whatever is the navel of the retraction, it's the same surgery, and with results to appears to be good from the authors. When the retraction is very, very patent, we can make an anteposition of material, then can be graft or biomaterial if necessary, but I don't like very much biomaterial because of the risk of exteriorization. We can use mucosa graft or aponeurosis, temporal aponeurosis graft for very important retraction. Here is a case, as you can see, the same approach, and we just take in place a part of aponeurosis on the plane, conjunctival and mular muscle plane. One point important for this technique is to manage a good conjunctival plane, avoiding contact with eye and the material you put to make the enlargement of your eyelid. Here is one example of this technique, and it can be interesting for the lower eyelid retraction. When we have a little retraction, we can only make the distension of retractors, but sometimes we have to add a plane, and the best technique is a natural graft permitting an enlargement of the inferior eyelid. You can use mucosa or hard palatine graft, and mucosa you can open the conjunctival plane. As you can see here, permitting an enlargement of the lower eyelid, but if you use biomaterial, please keep a good conjunctival plane, avoiding the contact to the eye. One word about retraction due to anterior lamellar disease, post-traumatic, as you can see. The first plasty is a Z plasty, for little retraction can occur good results. Be careful with keloid cicatrization, as you can see here, and if you have a big retraction, important retraction, post-traumatic in this case, you need a graft, dermal graft, with very good results on the upper eyelid. You can see here a big burning cicatrization and good results, permitting closing eye, avoiding ectropion with graft. So be careful on your pre-op exam. Be sure the aspect is due to retraction and not to proptosis or muscle abnormality. You can tell the type and the level of the retraction so that you can choose the good technique for you on local anesthesia so that the adaptation can be possible. I thank you very much for your attention.
Next, we have Dr. Alain Ducasse, who will be talking to us about surgical approach to orbital decompression.
Thank you very much. Professor Lee has talked a bit about this problem. What are the indications of orbital decompression? There are two types of indications. A functional indication in case of corneal exposure, or above all in case of optic neuropathy, despite medical treatment. Usually it's a grave disease. Another possibility is in a traumatic case with an orbital hematoma. And the second type of indication is aesthetic for proptosis, usually also in grave orbitopathy. What are the aims of the decompression? The aims are varied: to increase the orbital volume, to decrease the proptosis, to raise visual acuity on field, to decrease the intraocular pressure, and if possible without increase of the oculomotor disorder. There are three types of decompression: a bony decompression, 2 or 3 walls; a fatty decompression, it's the Oliveri operation; and a mixed decompression with fat and bone removed. The choice is made according to the importance of fat and muscle on the MRI and CT scan, and the state of the sinus. So most often we perform 2-wall decompression and removed of the palpebral fat pads. You can see here a CT scan in grave orbitopathy. There are big muscles and few fat. It's important to decompress to do an orbital and bony decompression in this case. You can see the muscle very large. The time of decompression is important. It must be before the other surgery, before an oculomotor surgery, and before palpebral surgery, as Olivier Galatoire said. The normal thyroid tests have to be normal, if possible, since 6 months. And around the surgery, we do corticosteroid to the patient. The fatty decompression, it's the lipectomy described by Oliveri. We remove the palpebral fat pads, the extraconal fat, and if possible the intraconal fat. Usually we perform this surgery unilateral because of the risk of blindness, which is important. Rarely done alone now for us, actually. The bony decompression, we use the technique of Ocular in 1962. We remove the medial and the inferior wall inside of the infraorbital canal, you can see here. And usually, rarely we perform 3 walls if it's necessary. The bony decompression, there are many ways to access to the orbital walls. The transcentral is the oldest technique by Garrity. We can have a way by a transconjunctival approach or transcutaneous approach by the medial counters, the upper eyelid crease, the subciliary way, or by a coronal approach as the Corneve did. We use most frequently an endoscopic approach by complete ethmoidectomy and meatotomy. It is possible to reach the medial wall on the inferior wall, and we can see and respect the infraorbital nerve. This is the picture of these two walls. It is necessary to have ENT material as nasal endoscopes with different optics, 0, 30 and 70 degree, video camera, and forceps as Blackesley forceps. And usually we always use the neuronavigation. The interest of the neuronavigation is to know where are your instruments during the intervention. Our techniques, we use most frequently 2 walls, inferior and medial by endoscopic approach, or medial wall by endoscopic approach and the lateral wall by cutaneous approach with ablation of the fat pads. We start the operation by the ablation of the fat pad, and after we remove the medial wall of the orbit and the inferior wall. The problem is the strut. The strut is the bone between the two walls, medial and inferior. Right in 1999, respect the strut because of the risk of diplopia, which for him less important in case of non-resection of the strut. Us, we remove it in all cases. If a lateral wall is had, we abort the lateral wall has a crown line, as I see to you this morning. We keep the anterior part, we keep the orbital margin, and we break only the posterior part of the lateral wall. You can see a short video by endonasal approach. We realize an ethmoidectomy, and you can see here here we are into the meatus, the maxillary meatus, and we have break the medial wall of the orbit, and you can see the fat into the nose. When you put on the eyeball, you can see the fat into the nose. The second side, we work always under the middle turbinatus, and we perform a total ethmoidectomy, and we break, as you can see here, the medial wall of the orbit here, and here the inferior wall of the orbit, and we remove the strut at this time. At the end of the operation, you can see there is no medial wall of the orbit, there is only fat into the nose. The advantages of this way is the rapidity, no scar, no pain, better visibility, fewer hemorrhages, fewer risk of endocranial aperture, and fewer lacrimal risks. Usually we perform the surgery in a bilateral way in one surgery. The disadvantage is the necessity of ENT material, and in France, the necessity of a double team. Thank you. The main risks are infectious with sinusitis, orbital cellulitis, and the muscular risk, more important than in cutaneous approach. The opening of the periosteum is more difficult, and the nose will be treated and have monitoring after the surgery. The complications are mainly sinusitis, infraorbital dysesthesias, new diplopia of increase of previous diplopia. We have performed a short study many years ago with 20 orbits with a follow-up of 3 years. We have separated 2 groups. In group 1, 2 walls by endonasal approach. In group 2, medial wall by endoscopic approach and lateral wall by cutaneous approach. You can see here the increase of the visual acuity, 3/10 in France in the 2 groups, and the visual acuity improved in 19 patients on 20. You can see here in the graph with before the surgery below and after the surgery in the left. The proptosis decrease also from 4 to 5 millimeters to 6 millimeters in the 2 groups. You can see here in the graph, and here it's more easy to see. The proptosis before surgery up and the proptosis after surgery in the bottom. The visual fields are all deficient before the surgery, and after the surgery 8 high are a normal field, normal visual field, and 12 have a visual field improved. On the fundus, there were 6 papilledemas before surgery. After the surgery, no papilledemas. And in the intraocular pressure, in the group 1, the pressure decreased from 3 points. In the group 2, only for 0.37. I don't know why. The complication is the main complication is the oculomotor disturbance with esotropy and diplopia. We have 7 diplopia on 11 patients. It was an increase of a previous diplopia in 4 cases and a new diplopia in 3 cases. All these patients had muscular surgery with recession of the medial rectus, and at the end of the surgery there were only 2 small esotropias and 1 diplopia. You can see a few days after the intervention. And the diplopias are usually delayed after 15 days or 1 month after the surgery, very often there is an important esotropia. The cause is the displacement of the medial rectus into the ethmoid, as you can see here, before the surgery on the left, and after the surgery on the right. The medial rectus are in the nose. You can see a patient just after the surgery in the hub and with esotropia, and after a surgical strabismus screen surgery, the result is relatively good. In conclusions, the decompression by endonasal way is very effective in case of optic neuropathy. It must be bilateral with lipectomy. It's a difficult surgery with possible serious complication. And if our president, your president is here, no? This is the day of the thesis in France when he worked in my hospital about the anatomy of the lacrimal nerve. You can see here a lacrimal handle, which is very, very rare. And the day of the thesis, and when he come back to the Lebanon in 1996. Thank you very much.
Thank you, Dr. Diaz. Next is Ocular Rejuvenating with Pectoral fillers by Dr.
Okay, thank you everyone. So we're going to go back to aesthetics again, and I'm going to talk a little bit about rejuvenating the periocular region with dermal fillers. So dermal fillers are very popular, and I'm sure as Lebanese you're aware that they are. And it addresses the devolumization, which is part of the facial aging process. It's something that can achieve outcomes that surgery alone cannot. And it's great because the trend in aesthetics is towards minimally invasive, minimal downtime procedures. So if you look at this survey that was done in the US it's a few years back, soft tissue fillers are about 2.3 million cases done compared to cosmetic eyelid surgery, only 200,000. And the gap is only widening. So in South Florida where I live, there's a lot of people walking around like this. And so sometimes patients come in and they say, oh no, I'm afraid of fillers. But what I like to tell patients is that fillers are really just a material for sculpting a face. But the final result really depends on the sculptor. So it's not the filler's fault that patients walk around looking like this. It really has to do with where you place the product and how you're injecting the product. So when I assess the periocular region, I like to look at not only the eyelids, but the surrounding aesthetic unit. So if you look over here, let me just get the highlighter. So along the lower lids, you can see what we talked about previously about some periorbital grooves and hollowing over here. You can see that there's deflation of the brow fat pad and a bit of hollowing of the superior sulcus here. You can see deeply etched in glabellar lines. You can see temporal wasting that shows the lateral orbital rim here. And then there's some mid-face devolumization as well. So I encourage you to really look at the surrounding areas when you're talking about periocular as well as panfacial rejuvenation. The first case here is a 53-year-old lady who came in saying, I look tired, I've tried all kinds of eye creams for the dark circles and nothing works. Well, as we talked about previously, no eye creams get rid of shadows. And if it's purely based on volumetrics, you have to address the topographical issues, not conceal it with creams or makeup. So here you can see on the bottom, there's a very mild amount of fat prolapse and then hollowing along the periorbital groove here. So surgery or fillers, in assessing what to do, if a patient has minimal fat prolapse and a lot of hollowing, they're better candidate for fillers, but I talk about blepharoplasty having better longevity. It's obviously more expensive and more downtime and has surgical risks, but with fillers, it's a slightly poor longevity. I typically quote patients as having the filler last along the lower lids at least about 1 to 2 years, sometimes longer. And I say that it's less expensive, and there's less downtime, and there's always a risk of vascular complications. This is my preferred injection technique for the lower lids and the periorbital grooves. I use a 23 gauge needle, and I inject on a 25 gauge cannula. I find that making your needle puncture further down away from the eyelids tends to minimize the amount of bruising around the eyelids. And then I like to fan from canthus to canthus. So I'll go up with a product. This is, in the US, it's called Bellatero. And it's a very, very low concentration hyaluronic acid that can be injected very superficially, anywhere from deep right to under the skin. And I'll just make multiple little vertical columns to blend the lid cheek junction for all across the orbital rim. And I like this technique because this filler can be injected superficially without much risk of a Tyndall effect, and it really diffuses into the skin very nicely. If you do something like Restylane that has a higher G prime, or it's more cohesive, you need to inject it deeper along the bone typically. But again, I not only do the nasojugal groove, but if they need it, all the way out laterally towards the lateral canthus. So this is that patient immediately post-fill of the right side only with 1 cc of Bellatero. And this is post-procedure day 1. And this is before and after at about 1 week. And you can see there's just a softening of the double concavity that we talked about previously, recreation of that shorter appearance of the lower lid. This is another patient, a younger patient. She's in her 30s, of skin type 5, a brownish Indian background patient, and I find a lot of my Indian or darker skin patients are very concerned about dark circles under their eyes. And you can see it, her pathology is very subtle. She has a little bit of lengthening of the lower lid over here. You can see a little bit of shadowing, a little bit of devolumization there. And after filling that area, it appears to have a shorter vertical height to the lower lid. And just the shadowing, the devolumization is mildly improved. This is the 3/4 view, again showing the relative shortening of the lower lid. So pearls for lower lid fillers, it's very important to choose an appropriate filler. Typically we want a lower concentration filler with a lower G prime. Bellatero is really my favorite, but the new Allergan product Volbella works very well. I definitely would avoid the traditional Juvederm Ultra, Juvederm Ultra Plus. They're very hydrophilic. They absorb a lot of fluid and they can migrate down into the cheeks. Sculptra, as you may know, that's a polylactic acid. You don't want to inject it superficially in a very delicate region like the eyelids with thin skin. And then where to inject, we talked about the lower concentration fillers being able to be injected more superficially. And needles versus cannulas, it's a personal preference, but I personally do prefer the cannulas. I feel it's safer, more comfortable, and not with a sharp needle close to the eye if the patient moves. So case number 2, these are all my office staff because they're always asking for free things, but this is a 45-year-old lady. She says that she's bothered by the upper lids looking hollow, and she says, do I need a blepharoplasty? I notice I have extra skin here. But I think, looking at her from across the room, you're noticing more of the hollowing, the elongation of the tarsal platform show, as we call it over here, that A-frame deformity and the shadowing of her superior sulcus here. And if you look at what's causing this hollowing in the upper lid, there's really two fat depots over here. You have the subbrow fat pad, which extends down below the superior orbital rim, and you can have true, hollowing of the preaponeurotic fat pad. In my practice, I prefer not to inject intraorbitally, so close to the globe in addressing the preaponeurotic fat. I like to inject the brow fat pad, and I'll show you my technique in just a little bit. Obviously, in this region, there's a supraorbital and supratrochlear nerves, and you need to be mindful of avoiding intravascular complications like central retinal artery occlusion and forehead necrosis. And ways to avoid this are you want to inject slowly with low thumb pressure on your syringe. You want to keep moving your needle or cannula. Again, I use a 25 gauge blunt tip cannula, so it's less likely to perforate the vessels. Even a 30 gauge cannula is like a needle and can perforate a vessel with enough force. Know your danger zone. So certainly the glabellar region and the supraorbital notch area are danger zones, and then keep hyaluronidase readily available. This is an example of my injection technique here. I typically like to make a little wheel of lidocaine just under the tail of the brow here. Then I make my needle puncture, and then I will insert the cannula, and you can see that I'm lifting the brow above the orbital rim with my left hand. I'm not injecting into the orbit. I'm injecting in a deep plane, which is the brow fat pad plane, right above the periosteum in this region. And the products that I like to use, I oftentimes like to, dilute it. So it's off-label, obviously, but I will pre-hydrate and dilute it with saline, and I find that this area tends to be very easy to overcorrect and cause edema. So pre-hydrating it and diluting it helps to avoid that. This is the patient before and after, and you can see it improves the amount of tarsal platform show here. The superior sulcus hollowing is better, and you can see it just changes the whole look of her brow complex and the fullness under the tail of the brow. This, if you toggle back and forth, you can kind of see the animation of how her brow contour changes and the tarsal platform show. And so pearls for this region, for filling the superior sulcus and brow fat pad, you want to lift the brow, inject deeply just above the periosteum. You want to inject, you don't want to inject superficially or anterior to the orbital septum. Be mindful of the neurovascular anatomy, and then also beware of hollow temples. And if the patient has a lot of hollowing the temple and you don't address this, filling and plumping the brow fat pad under the tail of the brow will look very unnatural and unusual. So really, again, it goes back to evaluating the whole complex and surrounding areas to have a harmonious appearance. This is a patient who I treated back during my fellowship in San Diego. She was one of our nurses who was a bodybuilder with about 5% body fat. And when she'd get ready for competitions, she would just become like a skeleton. And she said she actually lost points in her competitions for looking so gaunt. And here you can see there's severe temporal hollowing with showing of the orbital rim over here. She has superior sulcus hollowing. She has devolumization of the buccal fat pads, the cheeks, the nasolabial folds. And so we did a kind of a pan-facial rejuvenation on her. I injected different products. I injected Radiesse, which is calcium hydroxyapatite, into the temples. We did some Bellatero in the superior sulcus. We did a little bit in the cheeks, the buccal fat pads, and the nasolabial folds here. And this is an example of the before and after. Her look is a little bit softened. If I could go back and critique this, I would say, I could inject a little bit of Botox to her masseter muscle to further taper, ovalize her face and make it a little bit more feminine. But perhaps maybe you don't want to look too over feminine for bodybuilding competitions. So pearls for pan-facial rejuvenation, definitely discuss areas of deflation and pick your priority areas. If a patient says, look, I can't afford to do everything, I like to give patients a sense of how many syringes a full correction would be and say, look, you don't have to do this all at once. You can pick certain areas. And I like to say Rome wasn't built in a day. So analogously, we don't need to do a full correction all at once. We can pick your priority areas, come back in a few months, and build it up little by little. You have to know your filler rheology, which is a study of the physical properties of the fillers, to know which products to place in each location. And finally, we come to our last case, case number 4. This is a 63-year-old lady who came in with a 6-month history of enlarging mass right along, very close to the lacrimal sac region. She denied a history of tear trough fillers. She said no history of trauma, epiphora, bloody tears, or bloody nose. And we got a CT scan, and there looked like there was a little enhancing mass right alongside the lacrimal sac. And I said, you're sure you don't have any fillers? And she said, no, I've never had fillers in this region. So we did a biopsy here and encountered this rubbery mass over here. It appeared to be right up next to the lacrimal sac, but not invading into the lacrimal sac. And on pathology, we saw these giant foreign body, giant cells. We saw clear dropout areas suggestive of filler, some fibrosis, and clearly she had filler. And I questioned her later, and I said, I thought you told me you had no filler. And she said, oh, I had filler in the cheeks, but not in the tear troughs. But clearly, when the patients are leaned back with their eyes closed, sometimes they don't even know where the provider is injecting the product. So she had fillers right in that region, and it was a filler granuloma presenting many years later. Filler granulomas, they're about a 1% incidence with dermal fillers. They can present months to years following an injection. Treatment, if it's a hyaluronidase-based filler, definitely flood it with hyaluronidase. Get rid of that foreign material, and the granulomatous inflammation should go away. You can also mix it with triamcinolone to help get rid of the granulomatous inflammation. Other people have used 5-FU and bleomycin, or even for permanent fillers, some people are using radiofrequency devices to try to break up that product. And worst case scenario is surgical excision. But when you're looking at it on CT, filler granulomas are inflammatory granulomatous reactions, so they will always enhance both on CT and MRI. And that's really what helps differentiate it from a whole host of other benign and malignant lesions. And fillers are extremely popular and can address age-related devolumization. They're great adjunct to blepharoplasty and cosmetic surgery. If you feel like there's a little bit of hollowing after your blepharoplasty, you can go in and do a little touch-up with filler. But certainly be mindful of the devastating complications that can occur. Blindness, skin necrosis, granulomas. Know how to treat and prevent these complications from happening. And think of fillers as part of your toolkit in multi-modality aesthetic rejuvenation. So in my practice, I do surgery, Botox, fillers, lasers, peels, and topicals. And I think combining modalities really gives your patients the best outcomes. Thank you very much.
Next we have Dr. Adel Al-Suhaibani. He will talk to us about migrated permanent filler to the periorbital area.
Thank you. Good afternoon. It's good that my talk is followed Dr. Lee's talk, because he was talking mainly about the HA filler or absorbable filler. I'm going to talk to you today about my experience in managing migrated polyacrylamide filler, which is really a bad filler to deal with. And unfortunately, many people get this injected in Saudi Arabia, and I'm not sure if you have it here in Lebanon or not. As you just heard, that the soft tissue or augmentation with dermal filler is becoming really popular among customers or people looking for rejuvenation. And the advantage for it is the lower cost, as mentioned before, and this minimum time for recovery, and really in-spot or immediate change in the appearance that you can see following the injection. And as clearly shown by Dr. Lee before that, they are the second to botulinum toxin for facial rejuvenation. Filler can be injected in really multiple areas in the face, and can be injected below the eyes, in the cheek and temporal area, also in the nose and periorbital area, and also in the mandible. The expansion, really number of filler injection had really increased the interest for people to know more about possible complication and how can we handle this complication. And in general, we can divide this complication to immediate complication, early complication, or delayed complication. When you talk about immediate complication, we're talking about erythema, edema, pain, bruising, and vascular occlusion. And this, most of them are really goes with a short time unless you get unfortunate and you get vascular occlusion. What about the early complication? That we're talking about weeks after the injection, and we're talking about infection, hypersensitive reaction, discoloration, or cosmetic irregularity. If you are talking about the delay complication, we're talking again about infection, granulomatous reaction as nicely shown in the last case, and scarring and migration. Our interest today will be about discussing the polyacrylamide, which is non-absorbable biocompatible polymeric gels. It's around 96% water and 40% gel. It's injected in subdermal area, and it resembles fatty tissue, and after being injected, get encapsulated by a collagenous capsule. Filler migration to the orbital area was really reported in many articles following this material injection to the face. And in several cases, the material was injected in the lower cheek and corner of the mouth and migrated to the lower eyelid. Several really methods have been described to manage this one, and unfortunately, surgical excision remained the treatment for choice for this complication, meaning migrating permanent filler. In this study, we present the long-term outcome of surgical excision of migrated polyacrylamide filler to the periorbital area. We had this was done at the University Hospital along with Beirut Medical Center in Riyadh, and we reviewed the history of filler injection. And also the previous history of trauma or needling, and also we look at the size and shape and location of the migrated material. And this table summarizes the patient that we encountered during the study period, and we had 15 patients. The age range was between 24 and 57, and all patients were female, and you look here at the onset of the migration following filler, traced between 3 and 7 years. That means this problem will happen years after the injection. It's not expected to happen immediately after the injection. And the injected material was polyacrylamide because we were able to document it with the brochure the patient got. And in two patients it was not possible because it's really difficult to assess from the histopathology what kind of the material. And the size is really big. It ranges between 1 centimeter to 3.5 centimeters in the periorbital area. The size of the injection was the cheek in 9 patients. Temple and temporal area was in the 4 patients, and in 2 patients was injected in the nasal bridge. Most of the filler migrated was to the lower eyelid and the upper eyelid in 6 patients. Surgical excision was done for all these patients because it's really difficult to take them with other material like steroid or other material that can help decrease inflammation because it really doesn't respond well for this one. And the histopathological examination showed giant cell reaction in all these patients, and follow-up was ranged between 1 year to 8 years. What about the complication? We get 1 patient who had a recurrence 2 years after the injection, after excision of the migrated material, and 1 patient developed lower lid retraction. And this is one of the patients presented. As you can see, the patient presented with fullness involving the whole upper eyelid. The material was injected in the temporal area, and you can see how migration can be so distant from the place, and also can really mimic fullness of the upper eyelid. So if you don't ask these patients about previous history of injection, you may do blepharoplasty and you get caught in this kind of problem. And as Dr. Lee highlighted before, some of the patients don't volunteer to speak to you about this material, especially if they have somebody with them, like husband or somebody that they don't want them to know that they had a previous experience with the injection. So it's really good to take a detailed history. Sometimes maybe you need to sit in private with the patient and try to elicit the possible filler injection years after before the presentation. This is another patient who had injection of the filler in the cheek, and you can see the migration to the lower eyelid, and this is after surgery. However, even after surgery, you cannot take the whole material. You can see the material is still present here. The problem with the material that is infiltrating all the tissue, all different planes, and sometimes it's really becoming under the skin immediately, so it's really difficult to get it without making a skin hole. So it's really difficult material to deal with, and the problem is it doesn't respect plane and also infiltrate nerves and other structures. So it's really difficult to handle, and unfortunately, most of these patients are young, female, and active age, and they just become really badly depressed because of this complication. This is another patient who had nasal bridge injection, and this is the material, and you can see it here presented with small nodule, and this is after the excision. This is another patient who had really marked swelling of the lower eyelid and the upper cheek, and you can see it here. And this is an intraop picture, and you can see that in some of these patients, when you open, milky material comes out of it because of the necrosis and liquefaction of the material. And you can see that the whole cheek was involved. We managed to remove it, but unfortunately she developed depression in the lower eyelid. So I was thinking of just observing before doing anything else, because it may heal by itself, and this is what happened to this patient. And this is her picture 6 months after. With the granulation, the tissue build up, the eyelid build up itself. Luckily, this was not a material here. It was only granulation from the body to fill up that gap. So again, bioclamide is really associated with multiple delayed onset of complication, like induration, infection, inflammation, abscess formation, and delayed granulous reaction and migration. In one large retrospective study of 4,700 treatment, complication rate was 4% or 4.8% of this material. And in another study, they studied 66 patients who had previous injection of bioclamide, and they looked at the complication that patients presented with. The nodular formation was present in 30% of these patients, infection was present in 38%, abscess formation in 38%, and migration was the commonest among these complications. Management really depends on the individual complication and varies really from observation to intralesion steroid antibiotic treatment and to incision and aspiration with irrigation. Excision of this material by direct approach is the treatment of choice. However, I recommend not to go and excise from the first visit, because what happens if you excise it, the patient is really at risk to have recurrence. So the patient needs to understand the challenges that we face with managing this complication. And many patients, they try to go several doctors to help them or give them a word that, oh, I will take care of it and it will never go. But the problem is when they come to you, they'll tell you that we have been through many doctors and everybody is refusing to treat us. And you want you to save us. So, okay, you will be sympathizing with them, but at the same time, you need to document the complication and really a bad consequence that can happen from surgery clearly before touching these kind of patients. Filler migration can be early or late. And why migration happen? There are different possible causes. One of them is a poor technique in injection, a higher volume than can be accommodated in the injected area, gravitation, and muscle contraction. And the most common really one that promote is post-injection manipulation. What happens, some of these patients, they get it injected, and the treating doctor is trying to aspirate it with needles. And when they get it aspirated, they break the capsule that form around this material, so that will provoke more migration even to distal area. Careful precaution should be taken when injecting area of the skin, thin skin, especially around the eyelid. And in conclusion, with the raising use of injectable fillers, migration of material could be an important differential diagnosis in the periorbital area. Detailed history of cosmetic procedure should be elicited from such patients, because many of them, they will not volunteer unless you go and ask in details. Practitioners performing such intervention really have to be aware of this complication and the possible way of treating it. In majority of cases, patients undergoing surgical excision of migrated periorbital material tend to have a favorable long-term outcome. However, patients need to be aware of possible recurrence. Since this is my last talk, I'd like to thank the organizing committee and the scientific committee for having me and participating in this program. Really, I was overwhelmed with the great hospitality of people here, and also Lebanese people. And at the end, really, I want to extend my deep thank and regards to Dr. Ramzi Aladdin, and also for the president of the Lebanese Ophthalmology Society, Dr. Salah, and thank you so much.
Thank you, Dr. Sahibani. Next is Dr. Lee, and the topic is Retraction Injections.
Thank you. This is also my last talk, so I want to echo Adal's thanks to the entire LOS, the scientific committee, and it's been such a hospitable time over here. I've never been to a meeting where it was so well organized and such gracious hosts, and such a beautiful country. So thank you. So I'm going to try to cover a few tips of mine for injecting neurotoxins. I think, doing neurotoxins is fairly easy, but there's certain finesse points that, we can all consider and always trying to improve our practice. I'm going to talk about some functional as well as aesthetic tips for improving your injection technique. So to go back to that same table, neurotoxins are the most popular procedure, with about 6.7 million Botox cases back in 2014 and rapidly rising. At least in the US, I believe it's the same over here. The currently approved ones for cosmetic indications are Botox by Allergan, Dysport by Galderma, and Xeomin by MERS. But I will say that daxibotulinum toxin A is in phase 3 clinical trials, which is very exciting because based on their phase 2 trials, they showed that they had a longer duration of efficacy compared to Botox. So it remains to be seen if that bears out in phase 3. There's also various other Korean and Chinese toxins that are available on the market. They are not approved in the US, so I have no experience using them. What I typically tell my patients in terms of the timeline is that the toxin is bound within 4 hours of injection. It takes about 2 to 3 days typically to start working, and maximum results are in 1 to 2 weeks. And I typically quote them as lasting 3 to 4 months. I have had some elderly patients in which it lasts significantly longer than 3 to 4 months as well. And what are the typical aesthetic indications? All of us Americans miss this guy, but we won't get into politics here. Glabellar frown lines, so the corrugators contracting in the glabellar region, forward wrinkles, the frontalis, the crow's feet, which are wrinkles from the orbicularis oculi, muscle contractions, and then brow lifting and brow contouring, which are a function of both the lateral orbicularis oculi muscles as well as the frontalis. And then even for eye opening, if you inject the inferior orbicularis oculi, you can actually open the eyes just a little bit more, particularly when smiling, the eyes don't squint quite as much. In looking at patients for spastic conditions, whether for blepharospasm, hemifacial spasm, or for facial nerve palsy, particularly after Bell's palsy, there's a whole variety of other muscles that we're not as used to evaluating. So I always say it's very, very important not to just evaluate a patient in the static phase, but really good injectors will constantly have patients animate, try to elicit different types of spastic aspects of their muscle contraction, look for synkinesis. And this lady looks relatively normal when she's just looking at you. But here I asked her to smile, and you'll notice various muscles contracting. First of all, you'll notice that her depressor labii inferioris on the normal side shows the bottom row of teeth, whereas the paralytic side on the right is not showing the teeth. So one of the things that you can do is inject the normal DLI muscle so that neither side is showing the bottom row of teeth, and thereby helping to symmetrize her smile. Of course, looking at her smile, it's very obvious that she has a right facial droop, and the left side of the mouth goes up. So this is a function of both the zygomaticus muscles and the levator labii superioris muscles. And some patients, if you talk to them, they say, oh yeah, I'm really bothered by the asymmetry of this smile. And so I tell them, look, I can actually weaken the normal side so that it doesn't go up quite as much. But you also have to tell them, smiling is a very expressive human motion, and so you don't want to completely obliterate their ability to smile, so you don't want to overcorrect it because then they can't express themselves. Other muscles and things to look out for. Here you can see there's a synkinesis that occurs when she smiles. Many of these patients with facial nerve palsy, when they pucker their lips or open their mouths, their eye can close, and you can treat the orbicularis oculi muscle, weakening it so that the eye doesn't close when they move their mouth. You'll notice that her platysma muscle on the right side is spastic. And you'll also notice that the mentalis muscle on the right side is spastic. So all of these muscles are misfiring when the facial nerve regenerates after Bell's palsy. Then I have her do other maneuvers, I asked her, okay, now squeeze your eyes closed for me. And you can see other different synkinetic muscles firing together as well. On the right side, when she squeezes her eyes closed, her zygomaticus is contracting a little bit there. You can see her mentalis muscle, again, on the right side only, starting to contract there. And again, you see the platysmal band only on the right side, on the spastic side, also contracting. So these are all things that she couldn't exactly put her finger on, but she said, my face feels tight, it doesn't function normally. And these are things as an expert observer, you can evaluate and treat these very effectively. Actually, the primary thing that she came in for was that she was bothered by tearing. And she didn't really have any paralytic ectropion. Her lacrimal system was patent. And I explained to her that part of the problem here is that her tear pump mechanism is impaired, meaning that her orbicularis oculi cannot pump the tears down the puncta and the canalicular system. But she really had no physical obstruction, and I said, you could do the Jones tube, or we could actually Botox the lacrimal gland. So it's actually well known that secretory glands like the parotid gland, the lacrimal gland, do respond to Botox. And as you can see here, I can prolapse her palpebral lobe of the lacrimal gland, and it's a very easy and effective way of reducing the tear production from the gland. I typically do about 2.5 to 5 units. It's good to keep a very high concentration fluid to inject because you don't want it to migrate and for them to develop ptosis, which can occur with higher volume injections here. So now I'll just give you a few overall tips about injecting that I like to share with my residents and fellows. I always say, take a simple pertinent history. So, have you been injected with Botox before? Were you happy with it? Where was it done? I talk to a patient, I ask, how much movement do you want? Because some patients say, I want to be totally frozen, which personally I think looks unnatural, but other patients say, oh no, this has to be very subtle, I need to have movement, and I dose their injections accordingly. Any pregnant patients, I do not inject. I say if you're of childbearing age, make sure you take a pregnancy test. There's no significant systemic absorption, and there's been no cases of systemic botulism using doses that we inject on a cosmetic basis, which are typically under 100 units. But just for the medical legal reasons, if they're going to have a miscarriage, they're going to have a miscarriage, and they'll blame you if you injected the Botox. And then I also asked them if they've had any other history of neuromuscular weakness or facial paralysis. Number 2, we kind of covered already, but animate, animate, animate. You have to see the strength of their muscles, the pattern of contraction, any abnormalities, and then customize for their contraction pattern and their muscle strength. So again, you want to look for facial asymmetries, document this with photos, and point it out to your patients so that they don't say, "Doc, you caused this, you made my face lopsided." And you say, "No, actually, this is, we'll try to correct your asymmetry, but this was pre-existing." This was one of my patients who was a muscle-bound Marine. He had about 300 pounds of muscle, and he had very strong, forehead muscles, a broad forehead, and I did double rows on his frontalis. I told him he has, somewhat low-set brows with brow ptosis, so we can't go too aggressive on the lower frontalis. You can see the strength of his orbicularis oculi and the crow's feet, and you need to dose this accordingly. He's going to take a lot more toxin than my friend here, who's the Asian female with very weak facial musculature, very delicate muscles. Asian patients, in my experience, require much lower doses. Tip number 3, even though the packaging says to use non-preserved saline, almost everybody uses preserved saline, and I'll tell you why. 1, from a practical standpoint, if you're going to keep it beyond 24 hours in your fridge, you want bacteriostatic saline. And 2, if you've ever been injected with non-preserved saline, it burns. And so patients are much, much more comfortable with preserved saline. It is off-label, but this is what people in the aesthetic realm are typically doing. In terms of needles, I like to use insulin BD syringes. I find that there's less leakage with these needles. And then optional comfort measures are topical anesthetic with topical lidocaine. You can use ice. You can vibrate your finger, and wiggle to help distract the patient while you're injecting, and I find that's very effective as well. Tip number 4, we touched on this a little bit. The highest yield regions, especially for aesthetics, are in the upper face. Anytime you start going in the lower face, you can have good outcomes, but there's a very fine line between having an unhappy patient and a happy patient. The reason being is that we smile, we move our mouth so much for, rinsing our mouth after brushing our teeth, sucking through a straw, speaking, that, if you're a little bit off around the lower face, you can actually have impairment in certain functions. Tip number 5, I try to convince everyone that they need glabellar injections if they're interested in Botox. Some people come and say, "No, I'm really not bothered by this. I only want my forehead done." But nobody wants to look angry or frustrated. And the glabellar injection is the only area that will elevate the brows. There's many muscles that are brow depressors, the corrugators, the procerus, the orbicularis is a brow depressor, the depressor supercilii. There's 4 brow depressors and only 1 weak elevator, meaning the frontalis. So I always like to inject the glabella in everyone, particularly if they're having their forehead done. In terms of avoiding ptosis, which is one of our most feared complications with botulinum toxins in the periocular area, studies have shown that ptosis occurs due to either subperiosteal or preperiosteal tracking of fluid into the orbit and affecting the levator palpebrae superioris muscle. So when I inject the corrugator muscles, I use my thumb to mechanically block the orbit, and I inject a little bit away from the orbit, and I bevel the needle up. And then after doing the glabella injections, I do a bimanual V-shaped massage, massaging that toxin along the path of the corrugator muscles. And I find that this is very effective in preventing unwanted ptosis. Tip number 7, you must evaluate your patients for brow ptosis, dermatochalasis, and ptosis, because if they have any of these things, they constantly rely on their frontalis muscle in order to be able to see. And no patients want a baby smooth forehead with droopy brows or accentuation of their dermatochalasis, because at baseline they're used to using the frontalis muscle. So I always counsel patients and say, if you have any of these things, it's a trade-off. We can't completely smooth out your lower forehead, otherwise we're going to drop your brow. So I like to stay high, stay light, and definitely do the glabella as well to have that compensatory brow elevation. Tip number 8, I think the frontalis is actually one of the most difficult muscles to inject well, because there's such variety in terms of how elongated and how wide patients' foreheads are. And there's a fine line between causing what we call the Spocked brow, like Captain Spock from Star Trek, where you have a very unnatural, extraterrestrial appearance to your brows, or overdoing it and causing brow ptosis. So when you get that Spocked brow, it typically occurs due to failure to treat the lateral frontalis muscle. And that can occur from two mistakes. One of them is not extending your frontalis injections far out enough. So when I'm working with my residents, I say, I want you to mark out the lateralmost extent of the frontalis muscle, and then you have to make sure that you inject far enough laterally so that the toxin will diffuse and address the lateral frontalis muscle. The other fallacy is in patients who they say, oh, I'm only bothered by the 11 line, so I only want the glabella treated. I don't care about my forehead. Well, if you just do the glabella over here, there's migration of the toxins upwards into the forehead. And so what happens is that you get relaxation of the lower frontalis in this region, but the lateral frontalis is not addressed. So to prevent the Spocked brow, particularly in men, I do a 7-point injection. I do a baby dose of Botox or botulinum toxin to help prevent that Spocked brow and from having a strong lateral frontalis action, which will give them an unnatural look. Tip number 9, in terms of avoiding ptosis from the crow's feet area, I like to inject very superficially. Again, you can even inject intradermally into the skin or just subdermally between the skin and the orbicularis muscle. And I like to stay 1 centimeter from the orbital rim to prevent migration into the orbit. For very diffuse crow's feet, it's important to consider multiple smaller dose and double rows of injections, and also to counsel patients not to rub their eyes for the first 4 hours or so, not to get any facials, facial massages, or anything like that. Here you see a very fair-skinned patient of mine who also tends to be thin. I find that Caucasian patients with thin skin who have very little facial fat, they tend to have very diffuse crow's feet lines. And they're the ones who require double rows of injection points to really efface the full extent of the crow's feet. Patients who tend to be plumper or have fattier faces, or patients with darker skin, which is thicker skin, they tend to have more limited crow's feet, and you can get away with just a single row. And then finally, treating the inferior orbicularis for eye opening or hypertrophic orbicularis rolls or for under eye wrinkles is something that's very simple to do. As ophthalmologists, we're used to injecting the eyeball, injecting in the anterior chamber, injecting everywhere close to the eye. So even though this is close to the eye, I think all of us feel very comfortable in this region. But to always make things a little bit safer, I typically will have the patient look up. I'll distract the lid downwards away from the globe, and then I'll angle my needle horizontally, so even if the patient moves, it's not going to go right into the eye. This is an Asian patient with a very prominent hypertrophic orbicularis roll. Note, this is not orbital fat prolapse. This is a hypertrophic orbicularis roll. And when he smiles, his eyes become smaller and that roll becomes even more prominent. So he does not need a blepharoplasty, but if he's bothered by that puffiness, what you can do is put just 2 to 3 to 4 units into that hypertrophic roll, and then you can see when he smiles, his eyes don't contract as much, that roll is not quite as bulgy, and his eyes look bigger. So in conclusion, botulinum toxin injections are much higher yield in the upper face. With the right injector, they can be effective in the lower face as well. Proper injection technique can help prevent odd and unnatural appearances or ptosis of the eyelid. Injecting the lower face can certainly help with our patients with hemifacial spasms, with asymmetry from Bell's palsy or facial nerve palsy, and synkinesis. And proper understanding of the anatomy and all of the muscles, the mimetic muscles in the face, and customizing your doses and injection pattern will really yield the best results. Thank you once again.
Dr. Lee, please, have you answered the first question? We always say that the glabellar area is a danger zone for fillers. Same applies to the nasolabial area. Well, we always used to do extensive surgical dissection in the area and remove tumors, big tumors, and dissect all the weight and bone, excising everything, including the arteries and whatever, and never worry about ischemia to the frontal or the other area. Why should an injection of a filler intraarterial create ischemia, a big ischemic area, while we always used to excise tumors, in this area here, and not worry about it, even if we excise the artery?
That's a great question. Well, I think it's pretty well accepted how ischemia for the central retinal artery occurs. It's by retrograde injection under a lot of pressure. The filler migrates upstream and then embolizes anterograde into the central retinal artery. That's a great question that you point out. I think there's definitely, as we all know, the face is very, very vascular, especially around the eyelids. There's a lot of redundant blood supply. But I think if you inject enough of a bolus of filler, and there can be, when you get forehead necrosis, it's when you inject this in this direction, running upwards. And I think you do get distal migration of the filler, and for whatever reason, it's a good question, but it's a well-known phenomenon. Yeah.
I do have another comment or a question for you. You have shown us a case of hollow upper eyelid, and you have injected with the filler. My comment on this case is, you said you do not do a blepharoplasty. My comment is, if you do a skin-only blepharoplasty and shorten the skin and tighten it, then the effect of the filler would be much better than injecting a filler on a lax upper lid. This is my observation. This is my opinion.
Yeah, no, I agree. I think certainly she could have benefited from a little bit of a limited blepharoplasty.
Skin only.
Skin only, correct. But I think that in doing that, it wouldn't fully volumize the superior sulcus, the brow fat pad, change the brow contour as much. I have, there's a phenomenon in patients with very hollow eyelids. They don't have hooding of the skin. And what happens is that the skin invaginates itself up into the area of hollowing, and that's what takes up that extra skin. But in my patients who I'm doing a blepharoplasty on, like you said, exactly the same. I'll do a skin-only blepharoplasty, preserve all of the orbicularis muscle, and I do find that it tends to volumize the area as well. Yeah, thank you.
We have a question for Dr. Ducasse. How critical do you think it is to remove the posterior ethmoid bone, meaning the strut, for compressive optic neuropathy?
Can you repeat your question, please?
How critical is it to remove the posterior ethmoid bone, the bony strut, for compressive optic neuropathy?
We removed all the ethmoid wall in case of optic neuropathy, as deep as we can. And in endoscopic approach, you can see where you are very well, and you can see when you stop.
We have one last question, and that's for Dr. Galatoir. How predictable are the results of Botox injection for eyelid retraction?
They are for little retractions, spasmodic, as I show you. It's quietly, it's previsible, When for most important retraction, upper than 2 millimeters, you're not sure exactly of the results. It should be better, but perhaps not perfect. So that you have to inform of this the patient that another injection is possible, and if necessary, surgery on stability. Okay, Botox is very efficient when you don't have the stability of the disease, of Graves' disease, because, as you know, the navel of the retraction should move to the perfect stability of the inflammatory disease.
Dr. Galatoir, you have injected Botox posteriorly, subconjunctivally.
Yes.
Don't you think it might easily diffuse to the superior rectus? Isn't it better to inject it anteriorly through the eyelid?
That's a good question, I thank you. A constant debate in oculoplastic practitioners. You have the conjunctival sulcus who makes a good frontier, a good barrier between the malar muscle and the levator muscle, the rectus, In my practice, in my hands, it's less dangerous making it by subconjunctival way than percutaneous way, because you avoid, if the patients move, you can touch directly the eye or the rectus by the percutaneous way, and in my hands it's more predictable by the conjunctival way.
Have you had any superior rectus weakness?
No, we don't have this effect. I had more side effects with percutaneous way. I was doing it at the beginning of my practice. Welcome.
So thank you for your attention. We conclude the second oculoplastic